my pleasure to be with you in this morning. So the floor is yours, please.
Romania. It's a little bit of a weird way to talk to you. Last year I was in Brasov meeting you in person. Unfortunately, due to COVID, that is not possible now. But it is still my pleasure to talk to you, even though I cannot see you, about the latest insights into spondyloarthritis. That was the question I got from the organizing committee. What I will do today is talk a little bit about radiographic progression in axial spondyloarthritis. And usually we look at the clinical responses when it comes to treatment, but now I want to look a little bit beyond the clinical responses. This is my disclosure slide. Disclosure of potential conflicts of interests. I can declare you that I have received grants and honoraria for lectures and advisory board meetings from so many BD Mart developers and manufacturers that I cannot remind them. If you are interested, you can always send me an email. Not to forget, I was the president of the ASOS organization. And ASOS has stated already in 2016 that structural changes or radiographic progression are in fact extremely important. And there was a high level of agreement with regard to that particular statement. So structural progression, ankylosing spondylitis, very important. It actually reminded me of The Doctor's Dilemma. The Doctor's Dilemma is a play written by a playwright, George Bernard Shaw, more than 100 years ago, and he stated that in fact there is no harder scientific fact in the world than the fact that belief, mind the word belief, can be produced in practically unlimited quantities and intensity without observation or reasoning, by the simple desire to believe, and that is founded in the strong interest in believing. So beliefs are very important in medicine and also in ankylosing spondylitis, axial spondyloarthritis. How does that relate to radiographic progression? Well, with regard to radiographic progression in axial spondyloarthritis, there is one very common belief, namely that TNF inhibitors can inhibit radiographic progression. And that even though controlled data have plead against it. There's another common belief, and that is that IL-17 inhibitors may be better than TNF inhibitors in inhibiting radiographic progression, although we do not have data showing that these drugs have ever been compared. In fact, that study is still going on these days. You may wonder, why do we want to believe? Why do we want to believe that anti-TNF inhibits radiographic progression? Well, obviously that is because we have a desire to believe, and that is founded in a strong interest. If we look at the stakeholders that have an interest in believing that radiographic progression is inhibited by these drugs, then we have the physicians, the patients, society and payers, and not to forget pharmaceutical companies. It's easy to believe that patients have a strong faith in the value of inhibiting radiographic progression, for instance, because inhibiting radiographic progression may avoid bamboo spine formation. It may make them better functioning. It may give them a better health. It may optimize worker productivity, which is also important for physicians and from a societal perspective. It may, in the end, reduce the costs of healthcare. And it is very important to realize that if inhibition of radiographic progression is indeed relevant, it must truly be clinically relevant. And then we have the pharmaceutical industry. The pharmaceutical industry has, on top of these interests, also their business interest. They seek market differentiation in a market that is actually saturated by many drugs that work already quite well. In fact, so well that it is impossible to make distinctions between these drugs. In fact, all these drugs are equally effective. And what you should do then is making people believe that the effects that you see are indeed clinically relevant. Another word for that is marketing. You may wonder how, knowing that treatment effects with regard to radiographic progression are very small, that you need at least 2 years of follow-up before radiographic progression can show up, that it only occurs in a minority of axial SpA patients, and we do not know which patients it will occur in, and that the gold standard of RCTs, randomized controlled trials, they are very difficult to conduct in axial spondyloarthritis, especially when it comes to measuring radiographic progression. So what they usually do is resorting to publishing observational studies that are pimped with incomprehensible, very difficult statistics. And so may it happen that in the current world of fake news, quotes like "new treatment inhibits spinal deformity and ankylosing spondylitis" show up all of a sudden based on observational studies, which is an example of something that happened a couple of years ago. You may wonder, will observational studies ever give us the answer on the treatment effect of structural progression in axial spondyloarthritis, or should it be RCTs, randomized studies? Well, the answer to this question is definitely no. Observational studies will not give us the answer. Let's talk a bit about what observational studies for treatment effects actually are. Well, every study in which patients are followed over time and treatment is not assigned by a process of randomization is by definition called an observational study. So that also pertains to a long-term extension study of a trial that once began as a randomized controlled trial, but after some time was unblinded. Also, that is an observational study, though it began as an RCT. When we are talking about radiographic progression in axial spondyloarthritis, we should talk a little bit about how to measure it. Well, actually, it is still conventional radiographs. We measure radiographic progression in axial spondyloarthritis in the cervical and lumbar spine and in the sacroiliac joints. For the spine, we have the modified SAS, the MSAS, very familiar to you. In the sacroiliac joints, we actually don't have a score, but a modified New York grading system could be used for measuring progression. These imaging scoring systems have two very important problems. The first is that it takes 2 years before you see a sign of progression. The second is that if you measure it, it is very unreliable what to measure. There is a lot of measurement error. It is a difficult score. So let me introduce to you the signal-to-noise ratio. You may know this from electronics. Signal-to-noise ratio means that you only hear the signal if it is louder than the noise. So if you translate this to radiographic progression, then you have the signal-to-noise ratio represented as the level of radiographic progression in the numerator over the measurement variability in the denominator. And I can tell you that the signal-to-noise ratio of radiographic progression is actually very low. So that means a little progression and a lot of measurement variability. That also means that we need to have a lot of read precautions, scoring precautions. Those who score the X-rays, we need precautions for that, so that they pick up that signal. We need 2 or 3 readers in order to take the average score and to see the signal. We need statistical techniques that are required to increase the statistical power and the level of precision. So this is one important disadvantage of measuring radiographic progression in axial spondyloarthritis in observational studies. And if you look at observational studies, there are many epidemiological concerns. I'll mention a few. Right censorship bias, confounding by indication, and what I would call bias by historic comparison. I come back to that in a minute, what it means. It's all sources of bias and confounding in observational studies. First of all, right censorship, or attrition. Another word for that is bias by completion, or simply dropout. It is the phenomenon that you are very familiar with, that only the best patients stay in the study when you wait long enough, and the worst patients drop out over time. But when you are talking about radiographic progression, you know that the best patients that tend to stay in the study have least progression. So over time, they tend to give a positive impression of radiographic progression. Actually, the progression score lowers over time, and that is indeed what we see in many observational studies. Confounding by indication is a second very important form of bias that you see in observational studies. It starts when it is the physician, the treating physician, rather than a trial protocol that decides how the patient will be treated. And then it's very obvious and very common and very normal in clinical practice that the more severe patients will be treated earlier and more intensively by their physicians. And the less severe patients, in those patients you will wait a while or you give them less effective drugs. You try the simple drugs first. So altogether this means that prognostic effects of the disease and severity, as well as treatment effects of the drugs that you give over time, are intertwined and very difficult to disentangle. So that is a bias that you should keep into consideration. What is bias by historic comparison? Well, in the past, we have compared patients treated with TNF inhibiting drugs in ankylosing spondylitis with patients, with historic patients that were actually not randomized to not receiving treatment, but that were from an era in which TNF treatment was not yet available. It was, so to say, a historic control. That was in 2002, and in 2002 that made sense because that was the beginning of the anti-TNF era. But still we sometimes compare historically patients with untreated ankylosing spondylitis from 2002 or earlier with patients treated in 2020 with very effective drugs, not realizing that in these modern trials, actually the worst cases are not included anymore because they are treated regularly outside the trials with drugs already on the market, and you don't put that patient in a trial. It's actually very hard nowadays to find eligible patients for the studies. And if you look overall in those studies, the later actual SPA trials, those of the recent years, include patients that are generally less severe as compared to the very severe untreated AS patients in the early 2000s. That obviously causes a bias, and that bias is called spectrum bias or bias by historic comparison, and it plays a role in radiographic progression in axial spondyloarthritis. What you nowadays often see pop up in the literature is the so-called indirect comparison of two drugs. It actually looks a little bit as if the drugs have been compared in the context of a randomized controlled trial, but there was no direct comparison. The statistician that performed the indirect comparison actually took the data from two different studies. It's not a head-to-head trial. I consider indirect comparison a little bit provocatively a waste product of modern rheumatology because you see them increasingly appear in the literature. It actually comes back to doing complicated, sophisticated statistical analysis on different studies, words like network, meta-analysis, Bayesian approaches, etc. You may have heard of them, and those are statistical comparisons that to some extent allow you to compare across studies. You may wonder what is wrong here. Well, indirect comparisons rests on assumptions, on beliefs, so to say. The most important belief is that of clinical homogeneity. It actually assumes that the studies that you compare in an indirect comparison include the same patients, and that is rarely, if ever, the case. It also assumes that the different strategies that are used actually are more or less the same. The dosages are the same, the strategies are the same, and that is usually not the case. And then there is a strong belief in what I call incomprehensible statistical modeling. The techniques are extremely difficult, and it is a bit like you torture the data till they confess what you want to see. So let me show a few observational studies, actually only one, in which I have faith, not at least because I worked together with the investigators in this study to produce this particular paper that appeared a couple of years ago in the Annals of Rheumatic Diseases, and it is in the Swiss clinical quality cohort, the Swiss ankylosing spondylitis cohort, so to say. They investigated TNF inhibitor usage in an observational cohort, and they hypothesized the following, what I call causal chain. They reasoned, well, TNF inhibitors may lead to inhibition of syndesmophyte progression, so radiographic progression, by suppressing inflammatory disease activity. Well, it sounds like a very plausible hypothesis, and I will show you what they found. First of all, disease activity makes radiographic progression, is a driver of radiographic progression. That is something that we believe, but there is also proof for that particular statement. For example, in this study that dates back a couple of years by Sofia Ramiro, who very convincingly demonstrated, proved, so to say, that it is disease activity that drives radiographic progression. This was in the well-known OASIS cohort, and they showed that when disease activity is high over time, that radiographic progression will increase. And when you inhibit disease activity, that will lead to a reduction in the radiographic progression rate. So that part of the deal, that part of the causal chain was actually already very clear. It is actually demonstrating that there is a relationship between disease activity, that is represented by inflammation, MRI, CRP, etc., that turns into radiographic progression. This type of diagrams you are probably very familiar with. What did the Swiss people do? Well, actually, they demonstrated two things. They not only demonstrated that the use of anti-TNF in these patients independently reduced radiographic progression by approximately 50%, but on top of that, in addition to that, they also demonstrated that the effect was mediated by an effect on disease activity. So in fact, they were able to prove indeed that anti-TNF inhibits disease activity in patients with axial spondyloarthritis, and that that particular effect was responsible for reducing radiographic progression in these patients. Why does this all add to credibility? Why does this study make me believe more in the fact that TNF inhibitors inhibit radiographic progression? Well, actually, because the data nicely fit our expectations. There is, so to say, biologic plausibility for the beliefs that we had. Higher disease activity leads to more progression. TNF inhibition lowers disease activity. The Swiss demonstrated that TNF inhibition inhibits progression independently of other determinants of progression, and they showed that TNF inhibitors acted at least partially via inhibiting disease activity. So the chain was proven. Is this sufficient scientific proof, so to say? Well, actually, no, it isn't. It is still indirect or circumstantial evidence. But doing the trial is extremely difficult, cost a lot of money, it cost a lot of time. There is a lot of all kinds of disturbing factors. These studies, like I showed you for observational studies, this observational study is hard to comprehend. Most clinicians will have difficulties with understanding it, and they truly want the randomized controlled trial. There's one other argument: an observational study with a lot of statistics leaves a lot of room for, so to say, smart marketeers in pharmaceutical industry who will take advantage of the relative ignorance with regard to statistical problems among clinicians. So in the end, we still need the randomized controlled trial to convince all the people in the world and to close the history. Well, one of those RCTs is currently underway, and results will be expected within a couple of years, I guess. I've lectured quite a lot about inhibiting syndesmophyte formation in axial spondyloarthritis, and I give you examples of those lectures dating back more than 10 years at EULAR. In 2008, I thought TNF inhibition does not inhibit syndesmophyte formation because we compared TNF inhibitors with radiographic progression in OASIS and didn't find any difference. In 2014, 6 years later, I wasn't so sure anymore. I couldn't exclude some effect of TNF inhibitors anymore. It looked as if TNF did a little bit on radiographic progression. In 2017, I thought, well, there is circumstantial evidence accumulating that indeed TNF inhibitors and maybe other biological DMARDs may inhibit syndesmophyte formation and that it works via the inhibition of inflammatory activity. And 1 year later, in 2018, I lectured that incomprehensible observational studies pop up that will be used to make you believe, rather than that it is really true, that syndesmophyte formation can be inhibited. So apparently it didn't go fast enough, and many researchers, many pharmaceutical industries tried to convince you of the fact that indeed TNF inhibitors and other biological drugs are able to inhibit radiographic progression. Let me show you a few of those studies. This is the first one. It is actually the RAPID study in ankylosing spondylitis patients that showed a higher level of progression during the first 2 years as compared to the second 2 years. Well, obviously that is due to bias by completion, but by comparing these 0 to 2 and 2 to 4 years data of the RAPID axial SPA study with two other studies, two long-term extension studies that did not show that lower radiographic progression signal over the second part of the study, they tried to make you believe that indeed the drug used in the RAPID study had another effect as compared to the drugs used in those other two studies. Well, the most important remark on this particular slide is actually the disclaimer. The disclaimer that is on every slide coming from a pharmaceutical industry that we are talking about different studies and not a head-to-head comparison. And if you interpret that well, it actually tells you that you should take the conclusions of this type of studies with a grain of salt, not to pay too much attention to it. Why not actually? Because here it is into context. There is 0.67 unit progression in the first 2 years and 0.31 units progression in the second 2 years, but compare that to the relatively high baseline score of 13, 14 units, and you immediately see that what happens here is not clinically relevant at all. Again, there is a big question mark. It should be a disclaimer. Don't pay attention to this because there is too many biases that can explain this difference. This is another example of how people try to frame what you believe. It is a comparison of 3-4 different TNF inhibiting drugs, and the message of this picture is that in one of these drugs there is far less progression, only 20%, as compared to the progression that is seen with the other drugs. Again, we are talking about different studies. This is not a head-to-head comparison. These studies shouldn't be compared, and most probably the disclaimer here is more important and of higher relevance than the data shown in the panels. So what should we conclude about radiographic progression? Do TNF inhibitors and IL-17 inhibitors truly inhibit radiographic progression in axial spondyloarthritis? Well, they may, or they may not. I would say the jury is still out. We simply don't know. Only RCTs may give final resolution, but you shouldn't forget that we are talking about such tiny little differences that it may not really be very important to know whether they inhibit or not. Thank you very much.
Mulțumim.